In the 1970s, the Southwest Bronx was poverty-stricken. The Bronx was plagued by a wave of arson and was experiencing rates of unemployment and poverty that resulted in health and social conditions that mirrored those of a developing nation. Healthcare was sporadic and the quality was far below acceptable standards, evoking an outcry from many community leaders. It was against this backdrop that a small group of concerned citizens mobilized and formed a committee for better health care with the determination to combat the systemic cycle of poverty and inadequate access, to create a facility where they, their families, friends, and neighbors could get affordable quality health care. From humble beginnings, we've evolved into a healthcare network serving more than 48,000 patients. Our current objective is to grow the business to 70,000 distinct patients, to emerge as a center of excellence that is evidence-based, patient-centered, and data-driven. Now, this will require a large financial investment to migrate off our current electronic health record and practice management system to one that is far more efficient and can support the growing complexities of the business. Among the services that we provide are dental, behavioral health, health education, and other services that facilitate access to care. Now, we not only target health, but the social determinants that factor into health, such as nutrition, poverty, and education. We're located in a resource-poor urban community where we serve as an anchor for primary care resources, providing the necessary infrastructure for dedicated clinicians to care for the underserved. We are effective because of our connection to the communities that we serve, our understanding of their needs, and tailoring our scope of services to meet those needs to deliver culturally competent care with compassion and respect, regardless of the individual's socioeconomic status. With a large minority patient population, it is important for Morris Heights Health Center to incorporate awareness of health beliefs and behaviors, disease prevalence and incidence into our culturally competent delivery of services. We understand our patients' culture and linguistic differences, how these differences might affect care. So we try to eliminate as best as possible any language barriers and deliver care in a culturally sensitive manner. Metrics are an integral part of our organization. Today, more than ever, we must be able to demonstrate that what we do has a positive outcome for our patients. To that end, we measure the quality of services, its accuracy and appropriateness, staff performance and retention, patient and employee satisfaction, patient retention, and cycle time. We also measure financial viability such as return on investment, collection rates, and cost of providing services. We measure these metrics against industry and best practice standards. We're directed by a patient majority governing board. Our board members reflect the community we serve and manage health center operations, scope of services, and location decisions. Empowering patients to actively manage their own care and advocate on behalf of their communities also helps assure responsiveness to local needs. Morris Heights Health Center offers services on a sliding fee scale that is based on income. All patients are seen regardless of their ability to pay. Federally qualified health centers like ours all accept Medicare and Medicaid. And also, our staff mirrors our population. Roughly 60% of our staff is Latino and 30% are Black. We're proud to be an organization of many firsts. We were the first community health center in New York City to be accredited by the Joint Commission on Accreditation of Healthcare Organizations. In 1989, we were one of 3 national pilot models by the CDC and Health Resources Services Administration to demonstrate the integration and treatment of HIV within a primary care setting. We were the first community health center in the nation to develop and implement a childbearing center in a low-income community. And we were the first federally qualified health center in New York State to have received an award for quality of care. We are also the first to combine low-income housing tax credit with the Department of Housing and Urban Development Section 202 funds to create 70 units of affordable housing for very low-income seniors. For many years, we were the only major provider of primary care services in the Southwest Bronx. Over the subsequent years, other organizations realized what we always knew, that it is important to invest in these communities and that no community should ever be left behind. With growing competition surrounding our sites, we've met the challenge by remaining structurally nimble and open to change. We listen and involve our patients in all of our plans for service expansion, and we demand customer service excellence. Looking into the future, Morris Heights Health Center is positioning itself to serve a growing elderly population. In an effort to increase workforce development activities, we've initiated efforts to convert our workforce training and staff development activities into a comprehensive, coordinated teaching and learning center, the Morris Heights University. In addition to workforce development, Morris Heights University will focus on student placements for medical students, medical residents, and other graduate students, as well as community programs that bring education and training opportunity to individuals in the community. We also want to migrate off the current practice management system and expand and develop a much more coordinated care delivery system. In addition to care coordination across the organization, we would like to address many needs in our community that we currently cannot fill. To fill each and every one of these gaps, we want to broaden and strengthen existing relationships with hospitals and other health and social services agencies to avoid duplication of effort and most effectively serve individuals. We also would like to target comprehensive care for perimenopausal women. Youth programming in our organization is still largely clinically focused, and we would like to create a more comprehensive services model that integrates clinical, behavioral, and social factors to address socioeconomic disparities. We also aim to expand the coordination of care to a growing elderly population, linking hospital care with ambulatory care services.